This lecture video is about aphthous stomatitis, its etiology, clinical features, and treatment. Aphthous stomatitis is a disorder characterized by recurring ulcers confined to oral mucosa in patients with no other signs of disease. Recurrent aphthous stomatitis is classified according to its clinical characteristics into three types, that is minor ulcers, major ulcers, and herpetiform ulcers. So what is the difference between these three types of aphthous ulcer? So in minor ulcers, they are less than 1 centimeter and they comprise mostly 80% of the recurrent aphthous stomatitis, and they heal without scar formation. Major ulcers are more than 1 centimeter. They take a longer time to heal and they often form a scar when they heal. While the third type, herpetiform ulcers, they are seen as recurrent crops or dozens of small ulcers throughout the oral mucosa. These are the three clinical pictures showing minor ulcers. The first one is the minor ulcer, which is less than 1 centimeter. This bigger one, more than 1 centimeter, is the major aphthous ulcer. And this is the herpetiform ulcers, where small crops and dozens of small ulcers are seen on the oral mucosa. Coming to etiology of aphthous ulcers, these are all the etiologic factors for aphthous ulcers, that is hereditary, hematologic deficiencies, immunologic abnormalities, certain bacterial and viral infections, psychological stress, anxiety, allergy to certain foods, then disturbed menstrual cycle, and trauma. So we'll see all these etiological factors in detail. So first one is the hereditary. The prevalence of aphthous stomatitis is 20% among general population. So if both the parents are having recurrent aphthous stomatitis, there is a chance that the baby will also get aphthous stomatitis. There is a 90% chance. Then lesions appear at early age are more frequent and severe. Then hematologic and nutritional deficiencies. So 5 to 10% of the cases of aphthous stomatitis are due to hematologic or nutritional deficiencies. This can be due to iron, folic acid, or zinc deficiencies, or various vitamins such as B1, B2, B6, and B12 deficiencies, or also due to calcium and vitamin C deficiency. But in some cases, if the deficiency is not due to the vitamins, it may be due to a malabsorption syndrome, where he or she is having a sufficient amount of these factors, but there is due to malabsorption. Then bacterial and viral infections, various bacteria or viruses such as Streptococcal oralis and Helicobacter pylori, or various viruses such as HSV, HHV3, then HHV6, and Bacillus zoster can also cause aphthous stomatitis. Then psychological stress can also predispose to aphthous stomatitis. So it is most common that we can see aphthous ulcer among students who are appearing for their exams. So aphthous ulcer is most common due to that psychological stress which is in the students. Then allergy to a certain amount of foods such as milk, cheese, wheat. So there are patients who have allergy to these products. So due to that allergy, they develop aphthous ulcers. Then due to some flavoring agents and preservatives, uh, an agent in the toothpaste, sodium lauryl sulfate, can also cause aphthous stomatitis. And coming to clinical manifestations, aphthous ulcer begin in the second decade of life. They are most common on the labial and buccal mucosa. Lesions begin with predominant burning and from 2 to 48 hours before the ulcer appears. During the initial period, a small localized area of erythema develops, and within hours, a small white papule forms which ulcerate and gradually enlarges into the ulcer. The lesions are extremely painful and interfere with speech and eating. The large ulcers, they heal slowly and leave scars. So this was all about the clinical features of aphthous ulcer. So things to remember as key features of aphthous ulcer, which will be helpful in diagnosis of aphthous ulcer. These are six clinical features. That is, they are single or multiple round ulcers. They are never preceded by vesicles. They have regular margins. They have central yellow slough surrounded by erythematous halo, and they occur on non-keratinized oral mucosa. Coming to the treatment of aphthous ulcer, the mild cases can be treated with topical anesthetics. These topical anesthetics can be helpful in relieving of the pain associated with the aphthous ulcer, and in cases of major aphthous stomatitis, they can be treated with topical steroids or topical tetracyclines, either in rinse or in gel format. So these are the examples of all the anesthetics which can be used in treatment of aphthous stomatitis. That is lignocaine 2%, benzocaine 20%, and benzodiazepine hydrochloride. Then these are all the steroids which can be used for the treatment of aphthous ulcers. The topical steroids is the most widely used agent in the treatment of aphthous stomatitis. But for topical anesthetics, the disadvantages is that they don't have any effect on healing of the ulcers, while in case of topical steroids, they have certain side effects. So these are the drawbacks of the treatment of aphthous ulcer. And in major aphthous ulcers, some systemic agents are also tried, such as prednisolone 1 mg per kg per day, which can be tapered after 1 to 2 weeks. Then colchicine, cimetidine, dapsone, pentoxifylline, and certain immunomodulatory agents such as levamisole and azithromycin are also tried in the treatment of aphthous ulcer. Certain mouthwashes or mouth rinses can also be given to the patient, such as chlorhexidine gluconate, betadine, and tetracycline, and dilute salt water rinses to reduce the inflammation and bacteria in case of aphthous ulcers. Thank you.